Thanks for joining real quick, going through some pediatric airway and sedation management. See, it's in your HLCs. Make sure you've done that procedural sedation course on HLCs, and then after viewing this presentation, you will need to contact the education office to be signed off for the hands-on procedural sedation. That's the adult. We really want to just cover some pediatric stuff because peds are a little bit different in the approach from the adults. And with peds, I always say that, you know what, failure is not an option. And those two key points that you really need to pound in your head is this. Number one, you got to prepare. You got to prepare. And just know that if you fail to prepare for your procedural sedation, especially with pediatrics, you better prepare to fail. Anticipate the worst case scenario. If you do this, this is where what I call Murphy's Law is your friend. If you're familiar with Murphy's Law that says anything bad that can happen will happen. If you apply that to your procedural sedation and you know the proper steps to prepare, generally nothing bad is going to happen because you'll have prepared for every bad scenario, and because of that you'll catch the bad things before they turn bad. So that's really important. So a couple things about peds here. Number one, pediatric patients are not just small adults. They have very specific differences that change their medical approach and management. First of all, if you look at the pediatric airway, it is different. It's a lot different, in fact. With kids, pediatrics, their tongue is larger in proportion to their mouth than an adult's is. Their pharynx is much smaller. The epiglottis is larger and floppier. So on intubation and on controlling kids, it's very easy to obstruct their airway with a big floppy epiglottis, and it's hard to intubate sometimes. You got to get under that epiglottis. A lot of times the doc will want to use, I know in Skylife we use I like to use a Miller blade instead of a Mac because you can hook underneath that epiglottis and pull it up. Their larynx is anterior and superior, which means it's more forward and more up than an adult's. And their cricoid, and it's funnel-shaped as opposed to an adult's, which is more straight. And the trachea is narrow and less rigid. So their head also is larger in proportion to their body, which causes a normal chin to chest position when you lay on your back. Most adults, when you lay flat, you can kind of put an adult in what they call a sniffing position and you're fine. You lay a pediatric because their head's so large, they'll get this chin to chest position and it naturally obstructs the airway. So when kids are lethargic, if they're tired or they're sedated, a lot of times, as you can see on the bottom, you got to put a pillow or a rolled up small towel in between their shoulder blades to extend their chest and get that sniffing position to open up that airway. Another thing about infants, you got to remember that they're obligate nasal breathers. If you've ever seen kids breathe fast, they're breathing through their nose like crazy. They don't naturally want to breathe through their mouth unless they're screaming. So you got to know that. So nasal, facial injuries, swelling, a lot of secretion from crying, anything that obstructs their nasal passages is going to make them more anxious, is going to make them freak out. So you got to keep them, number one, calm, and number two, you got to keep their nasal passages clear. They're diaphragmatic breathers. If you've ever seen a small kid breathe, they're breathing through their bellies, in and out through their bellies. Their bellies pop all day long. They don't have the musculature development yet in order to use their rib cage. It's something that we call bucket handle effect. They have a real minimal bucket handle effect. And what that is, when you look at a picture of a bucket handle comes out and away from the pail itself. Adults, your rib cage, when you breathe, they come out, they expand, and they come away from the chest cavity, increasing the diameter of your thoracic cavity, which increases the volume with which you can inspire. Kids can't do that. They're pretty much dependent on their diaphragm. So anything that obstructs their diaphragm from moving is going to impede their ability to breathe. So one of the things with kids, if you notice, because they're nasal obligate breathers, what do they do when they breathe? They're screaming, they're snorting, they're sucking in all sorts of air. All that you can see on this slide here, all of that inspired air, that's just distended gas in the abdominal cavity, or in the stomach, excuse me. So all that inspired air, what is that going to push up on? It's going to push up on their diaphragm. That's going to limit their ability to take a deep breath and get that deep. And when they do, it hurts. And if they continue to suck in air, what's going to eventually happen to our peds? They're laying on their back, they're going to vomit, right? All that big burp's going to come out with all the food, and now you've got an obstructed airway or a very difficult to manage airway, and now you've got a really angry, tweaked out kid. couple of formulas you want to really memorize. And you want to have these memorized in your head because these will really save you. One of them is systolic BP. Age times 2 plus 70 millimeters of mercury is your bottom line minimum BP for that particular age kid. So remember that, age times 2 plus 70. 80 millimeters of mercury give you your mean BP. That's what it should be. So pound that one into your head. The other one that is the most important, you got to have this one memorized, which is age times 2 plus 10 kilos. That is going to give you your average weight for a kid's age. And I'm telling you, this thing is going to get you within 2 to 3 kilos of the Broslow tape. Now, the reason I want you to be able to do this, age times 2 plus 10 kilos, is because the time to be thinking about what volume of pediatric drugs you need, right? Everyone freaks out with peds drugs, and naturally so. They're different volumes. A lot of times you need a 1 ml syringe because you're talking 0.2, 0.3 cc doses. And if you don't have that stuff on hand and ready to go, and all you have is a 3 cc syringe, you're going to be freaking out. So if you prepare for all this ahead of time, like I said at the very beginning, you're not going to have that anxiety. You're going to be ready. A couple other formulas you got to know. IV fluid bolus, you should all know from PALS, even ACLS. A fluid bolus is 20 mils per kg, right? For kids, blood is very easy. It's half that. So think fluid is 20, half that's blood, right? Because generally you're not going to need as much blood as fluid. So it's 20 mils per kg for your fluid bolus, and it's 10 mLs per kg for your blood. When we do our hands-on portion, we're going to give you an opportunity in order to do that, to look at this stuff so you know what's in there. Like I said, familiarity and preparation is your key to calm, smooth, cool, and collective. I call it the ABC rules. Always be cool when you're approaching this stuff. And how you do that is you got to know your equipment and you got to prepare. So some basic airways that we all should be familiar with, right? The OPA and the NPA, oral and nasopharyngeal airways, just good old head position. Most of the time, if you get someone into a sniffing position with a jaw thrust, you're not going to need anything. I'm telling you, 80 to 90% of the people don't need an OPA or an NPA if you just maintain good head position, right? Your advanced airways are things like the LMA, the laryngeal mask airway, the EOA, if you remember that, the esophageal obturator or the King airway. These are mid-level kind of advanced airways. Definitive airway, the only definitive airway is an endotracheal tube. We'll talk about that. And then you got your surgical airways, a needle crike, surgical crike, and a surgical trach. First of all, your basic airways, OPA and NPA, when are they indicated? So there's some clear indications. Some people just go ahead and grab an OPA on a semi-conscious patient and throw an oral pharyngeal airway in to be completely shocked and surprised that the patient vomits all over the place or spits the airway out. You don't use OPAs on patients that are semi-conscious. That's for unconscious patients. If your patient's semi-conscious or in deep sedation, whether intentional or accidental, the NPA, if you cannot get an airway using good, solid, basic airway maneuvers, your NPA, nasopharyngeal airway, is your airway of choice. It will not stimulate the gag reflex, and it will provide an adequate airway through their nasopharyngeal airway. It's fantastic. Now, if your patient's unconscious, then you want to go ahead and use an OPA. That's definitely the airway of choice. You do not want to use nasopharyngeal airways on patients with any type of facial trauma, because if you cause damage inside their nose, inside their turbinates, you rip apart a turbinate, or there's a clot in there that you break loose, you've now just created an unstable airway by breaking a clot loose, and now they're bleeding to death in their mouth. A few things about oxygen delivery to look at real quick. Your nasal cannulas delivers at the different liters 1 through 6 up to a max of about 44% of IO2 on the nasal cannula. It's good airway if you've got good nasal clearance and you can breathe well through your nose. It's fantastic, and you don't need a lot of O2. Simple mask to deliver 35 to 55% O2, airflows of 5 to 12 liters. You can create a simple mask from your non-rebreather very easily. Sometimes a non-rebreather is a bit overkill, so you just want a simple mask. If you take the bag part, that piece of tape on there, and tear that off and pull off the 2 nose tabs, there's a little plastic piece inside the packaging bag that the non-rebreather mask comes in. And you probably know that little piece because it always falls out onto the floor, and you say to yourself, What the heck is that little piece for? Well, it's to turn your non-rebreather mask into a simple mask. You pull off the bag, just grab it and tear it off. Put on that little cap and plug the airway tubing right to that. Pull off your 2 non-rebreather valves on either side of the mask, and you've just created a simple mask. If you look at a standard non-rebreather bag, it's got about 1,700 mLs of air in it, right? A 100 kilogram adult at about 8 mils per kilogram, which is what the average is, 8 to 10 mils per kilogram for your volume of inspired air for an adult. It's about 800 mils, or about half of a squeeze. So a half a squeeze of a bag is ample volume. You don't do the two-handed death squeeze, giving barotrauma and shoving the rest of that volume down into your patient's stomach. So you don't need to go cray-cray. You don't need to go aggro. Nice, easy, small, even squeezes, slow, control the volume of the air coming out so that your patient can get a full breath and not too much. 3 things make it a definitive airway. It's got to be in the trachea, it's got to be secured, and it's got to be connected to O2. Once those 3 things are checked off, you have yourself what we call a definitive airway. One thing is called the aeropharyngeal exam. It's called the 3-3-2 rule. There's the Mallampati classification, the Cormack-Lehaney. It's more when you're intubating what you see when you actually get the blade in there and look. The 3-3-2 rule. Can you fit 3 of your fingers inside the patient's mouth? That lets you know how much open mouth clearance they have to work with. Have you ever seen someone open their mouth and they're like, ah, and it looks like you could fit maybe a quarter in there? You're like, oh boy, that's a really small mouth. Mental note. If you can fit 3 fingers in there, that's great. The other 3 of the 3-3-2 are 3 fingers that evaluates the length of the mandibular space, which shows you, how easy it's going to be to do a jaw thrust on that patient, how easy it's going to be to open their mouth to be able to get airway adjuncts in there. And then the 2 of the 3-3-2 assesses the position of the glottis in relation to the base of the tongue. If you can't pass the 3-3-2 rule, it's just kind of a mental note. Okay, small mouth, short neck, that could be a problem. The other one that you can all do is called the Mallampati classification. All you do is tell the patient, open your mouth, stick out your tongue, and say, ah. Look in their mouth. What do you see? If you can look in their mouth and you see all the way to the back of their posterior oral pharynx and their epiglottis, or their uvula hanging down in the back of their throat, that's a class 1. That's a really good sign to let you know if things go sideways, they got pretty good airway clearance, you're probably going to be able to intubate that patient, no problem, fit in OPAs, probably do a good adequate jaw thrust, and get basic airway maneuvers. So class 2 is, they open up, you could still see the uvula, but it's a little bit of a dark cave back there. Class 3 is like, oh my gosh, they say ah, they've got a huge tongue. I can barely make out a portion of their posterior oral pharynx. And class 4 is like, they open their mouth and you're looking at their soft palate. Medications that sedate moderately and deeply. Common meds that we use, right? Versed, we don't use a lot of Valium here. Ativan sometimes is used, but remember your Ativan's much longer acting than your Versed as a benzo. So kind of the go-to benzo is Versed. Narcotics, morphine of course, much longer acting. Demerol, not really used anymore. We took that one off the formulary generally for any type of sedation. Fentanyl, right, and Versed are the 2 that we use most as far as a benzo-narcotic combo. Now remember, it's the benzos and the narcotics together that are going to cause a lot of respiratory depression, so just be aware of that. Less so with the fentanyl, and you're going to get much less of that histamine effect. You have much less blood pressure problems using fentanyl. I always kind of push for more fentanyl than Versed. Get them a little Versed just to get them a little sleepy and relaxed. Then you can push your fentanyl at much higher doses. You start pushing a lot of Versed, I guarantee you they're going to stop breathing. For the deeper sedation stuffs, we got our ketamine, which is a great drug. Propofol, of course, pretty common. Etomidate, we use that mostly for intubation induction, but for quick hips and stuff like that, don't be surprised if we use a little etomidate. Propofol, or what we call is the fentanyl, little fentanyl and propofol, is pretty common. Ketamine is becoming a lot more popular, even more with adults. Kids, it is definitely the go-to drug, I would think. But again, this is physician discretion and choice on what he wants to use. For kids, I always push for ketamine, and even some adults, especially if they got what might be a really, really difficult airway. And what's the reason for that? Why is ketamine a lot safer. The reason is it doesn't cause a respiratory depression. They maintain their respiratory drive. It helps them relax. Some side effects and some downsides of ketamine is it can cause hypotension if you push it too fast, and it can cause vomiting, and it can cause some laryngeal spasms. And those side effects are generally only if you push it super fast. So some doses you probably want to pop in your head. I'll probably have a small badge buddy for this kind of stuff. But ketamine, 2 mg per kg, 5 mg per kg IM if you're giving it intramuscular, 2 and 5 there. For SEDS, generally 0.1, maybe 0.2 mg per kg. Propofol, there's a range there, but I just 2 mg per kg, 1 to 2 mg per kg. And then the etomidate is 0.2 mg per kg. It's good to have that on a little card because you get a little nervous, especially if this stuff pops in last minute. Analgesia, fentanyl, 2 to 4 mics per kilogram is pretty standard. Sometimes 1 for the peds. Quick word on the NMBAs, the neuromuscular blocking agents. We don't use, I'll just mention this, we don't use a lot of succinylcholine anymore, although there are some that do. It's kind of phasing out ever since we got rocuronium, which is the non-depolarizing, real safe one. But succinylcholine, the 2 different types. So you've got the non-depolarizing, which I call blockers, and they block the receptors at the neuromuscular junction there. And it basically blocks that and prevents the muscles from being fired from the acetylcholine coming off the axon terminal. It's going to innervate that. So it prevents, it's a blocker. Things like succinylcholine are binders, and what they do is they literally bind to that site and they cause a firing. So if you do give succinylcholine, you'll notice just about every muscle fiber in their body will start twitching. That's totally common. It's depolarizing all the muscles while it binds it. Confirmation, if you do end up intubating, remember visual, fogging of the tube, auscultation, chest wall movement, end-tidal CO tube, there's bulb suction test, chest x-ray to confirm the depth and position of that ET tube are all things that you want to make sure are being done. And the RTs and docs are real good at that, of course, but we need to know that too. People can ventilate and they can hypoventilate. Well, he's got chest movement, he's breathing, yes, but he's not breathing adequately. He's just moving dead airspace back and forth. So respiration and ventilation are pretty vastly different. You can be respirating but not ventilating appropriately. So, try holding your breath. Remember, people turn red before they turn blue. Your patient starts turning bright red. You'll notice this when people stop breathing, they get real red, they get tachycardic, and then they'll start turning blue. If they're turning blue, you are way behind the ball. If it's unsuccessful, make sure you hyperoxygenate people if you have a bad outcome or anything like that before you do another attempt. Hyperoxygenate the tissues. That will save you and your patient from a lot of pain and probably death. So equipment we've got to have present during the procedural sedation: blood pressure monitor, cardiac monitor, pulse ox monitor, end-tidal CO2 for procedural sedation. Absolutely a must. I really think any of our procedural sedations should be done in the recess rooms, and these carts are there, Brasilo, crash cart, everything is in the room. So you got to have a crash cart, appropriate oxygen flow meter, suction, no doubt, got to be on and ready to go. Suction's got to be on and ready to go. Manual, a bag valve mask should be out, hooked together, ready to go. If you don't use it, you just put it away, but have it out. Reversal agents, Narcan, right? Got to use the Narcan for the narcs. You got to use the Romazicon for the benzos. And there's no, the only reversal agent for ketamine and propofol is time, T-I-M-E. Assessment, scoring, and ongoing monitoring of vitals and pain. An EPIC document on the procedural sedation flow sheet is prompted. I'll show you where that is in a minute. You got to make sure you get your pre-procedure checklist done, which includes part of the timeout. It'll ask you questions there on the flow sheet. You can get to that on the narrator or the doc flow sheets. During the procedure, you want to make sure that we assess and score every 5 minutes. Now, sometimes, especially if you're shorthanded, you don't have time to sit there and document and monitor your patient. If you're solo, if it's just you and a doc and a tech, obviously you want to get more hands if you can, but if you're busy and you're doing the solo, the patient takes priority. Grab a piece of paper, jot down your vitals, or make sure your monitor's set for every 5 minutes and pull it off later. But your patient's king, not the monitor, so monitor the patient. Every 5 minutes, end a procedure, every 5 minutes until they're stable or reach their baseline again, then every 15 minutes. Always document the universal protocol verification and the correct patient, correct procedure, site, both in pre-procedure period and with the timeout just before the procedure. Monitor your patient in their recovery phase. That's many times the most dangerous phase because they don't have pain as a stimulator to breathe through the narcotics or sedation. So every 5 minutes, monitor their airway. That means you got to look at it, look, listen, and feel, make sure they're breathing. You can put their head up a little bit, maintain a little better position, whatever position that particular person or pediatric patient needs to breathe best, do it. 5 minutes, starting from the time the sedation drugs are administered through the entire procedure, then for another 5 minutes after that till baseline, then every 15 minutes or Q protocol. Monitor for at least 30 minutes after the last dose of sedation was given. If reversal agents are used, important, monitor for at least 2 hours. You just type in the word procedure. If you click on flow sheets, it'll bring up, you can see it right there, ED adult and ED pediatric. This is what the flow sheet looks like on the narrator. Document also, don't forget the REACT score if your patient's 13 years and younger. The REACT score is also a flow sheet that you can do. Prepare, prepare, prepare. I'm telling you, if you do this, life is good for you, it's good for your patient, it's good for the country, it's the best thing all around. Number 2, know thy equipment. You got to get your hands on this stuff, get it out, get it ready, mess with it, play with it, stick it in your friend at home, use it on your pets. I'm just kidding, don't do that. But just get familiar with it, right? And number 3, anticipate pitfalls before they happen. Use your Mal and Patty scoring, look at their airway, assess everything and say, ooh, if you say to yourself, oh, mental note, if this goes sideways, it's going to go completely sideways. Get your stuff ready. Document your procedure with the necessary paperwork. If you got other questions we didn't cover here, please contact us. Let us know. Darlene and I will be available to answer questions for this.